Yeah, good afternoon. My name is Hermann Einsele, and I am the chair of the Department of Internal Medicine 2 in Würzburg, Germany. And we run a large multiple myeloma program with about 2,000 myeloma patients per year, and also have a large immunotherapy program. So the topic of my talk today is incidence, mitigation, and management of neurological side effects in patients with multiple myeloma treated with cilta-cabtagene autoleucel in CARTITUDE-2. Cilta-cel autoleucel or Cilta-cel is a CAR T-cell therapy. CAR T-cells means patient-derived T-cells that are genetically modified, which allows them to recognize the myeloma cell. And the specific thing about Cilta-cel is that it has two BCMA-targeting antibodies. Now, BCMA is the target on the myeloma cell that is most commonly addressed by CAR T cells. Now, the CARTITUDE-2 study is a phase 2 multi-cohort open label study assessing the efficacy and safety of this CAR T-cell product in patients with multiple myeloma in various clinical settings. Now, treatment emerging neurotoxicities are known side effects of CAR T-cell therapies and can be mild, so that the patient is not really experiencing or feeling and noticing them, and they can also be life-threatening. And so these require careful monitoring and management. Now, in the previous study, the CARTITUDE-1, which was very successful, so in very heavily pretreated patients, this CAR T-cell product had an overall response rate of 97%, with 2/3 of patients, in spite of 6 prior therapies, achieved a complete remission. So very effective. But in about 10% of patients, they saw some neurological adverse events, in some of them occurring quite late after CAR T-cell infusion, often with symptoms of a Parkinsonian type. And now the question was whether better mitigation strategies might be able to reduce or to prevent this neurotoxicity in patients with multiple myeloma that received Cilta-cel after 1 to 3 prior lines of therapy. Now, this is the Cohort A, which I'm going to explain. In Cohort A, patients that were progressing with their myeloma after 1 to 3 prior lines of therapy included a proteasome inhibitor and an IMiD, and being lenalidomide refractory were included in this trial. The endpoints was overall response rate, very good responses, including MRD negativity, the duration of response, and the incidence and severity of adverse events. And here you see the study design. Following screening, apheresis, the patient received the bridging therapy for a better tumor control. Then the lymphocyte depletion was done with cyclophosphamide and fludarabine. Then the CAR T cells were infused, and the patient assessed for safety and efficacy. And these were the patients that were included in this trial. They were not as heavily pretreated as in the CARMA or the CARTITUDE-1 trial, but 15% had an extramedullary multiple myeloma, 15% had a bone marrow infiltration of more than 60%, 40% were triple-class refractory, and all the patients were refractory to last line of therapy. So not as heavily pretreated as in CARTITUDE-1, but also highly refractory patient. Now, from CARTITUDE-1, they knew that there are certain risk factors for neurotoxicity. And these are high tumor burden, a high cytokine release syndrome, grade 2 or higher, a previous ICANS, and a high CAR T-cell expansion and persistence. So how did they change the treatment to prevent this neurotoxicity? So first of all, they introduced a more effective bridging therapy to reduce the tumor load and thus to prevent a patient to undergo CAR T-cell therapy with a high tumor burden. Second one is early aggressive treatment of CRS and ICANS. So if there is a cytokine release syndrome or some neurotoxicity, it should be treated early. The second one is to better screen for neurotoxicity. So what they did was a handwriting assessment and an extended monitoring for neurotoxicity. So here again are the strategies: more effective bridging therapy, neuroimaging, monitoring strategies, and a better management strategy. And I just wanted to show you what kind of monitoring they did. So they did an analysis of the orientation of the patient. So the patient was asked to name the year, the month, the city, and the hospital. Then 3 objects had to be named. Then it was assessed whether the patient was able to follow commands. Then there was some writing analysis, and also attention was checked by asking the patient to count backward from 100 by 10. And this is the handwriting analysis, which also in other studies was very helpful to detect early neurotoxicity. So if there was micrographia, so abnormally small or cramped handwriting, that was an early warning sign for neurotoxicity. Dysgraphia, illegibility of writing that takes an unusual long time or great effort. Or agraphia, pathological loss of the ability to write. So all these were parameters that were checked in these patients after CAR T-cell therapy to early detect neurological side effects. And by this, neurotoxicity was seen in only 20% of patients, and only 6% of patients actually had a grade 2 ICANS. So it was very acceptable. And the treatment that they used was steroids, and with steroids, the neurotoxicity resolved in all 3 patients. And none of the patients developed grade 3 or higher neurotoxicity. None of the patients developed this Parkinsonian-like syndrome following CAR T-cell therapy. So in summary, neurotoxicity was generally manageable in patients with multiple myeloma following treatment with Cilta-cel. The incidence of these movement and neurocognitive severe events that were seen in the CARTITUDE-1 trial, so these Parkinsonian-like symptoms, could be completely prevented. There was no grade 3 neurotoxicity. And so this data clearly show that early detection and management of neurotoxicity can help to optimize patient care. And they now have a subsequent patients dosed more than 100 patients across the CARTITUDE study program, and suggest that these new patient management strategies have been successfully implemented and prevented this late onset Parkinsonian-like neurotoxicity, but also earlier grade 3 neurotoxicity. Now with this, I'm at the end of my presentation. I want to thank you all for your kind attention.